CAR T cells are modified normal immune cells from the patient, autologous setting, that are modified so that the tumor cells are recognized by the immune cells. Um, Now, in myeloma, the BCMA is the target currently, and BCMA is expressed only on myeloma cells and normal plasma cells, but no other cells in the body. So when the CAR T cells are infused with this specificity, it will only go to the tumor cells in the bone marrow and or wherever the tumor cells are. So that's the first thing that it makes it specific. The second is that the killing is by immune mechanism, how a normal immune cell kills the tumor cells and or kills a cell that is infected with virus or others. And so in this case, the killing mechanism is very different than the traditional killing by chemotherapeutic agent, proteasome inhibitors, and other methods. And so none of the usual resistance mechanism are usually operating. And that's why when we have a specific targeting to BCMA and killing by immune cells, the overall efficacy becomes tremendously high. And that's why when we look at the BCMA directed CAR T cell therapy by all different companies and different products, the responses are 80 to 100% in very late patient population. And that's the reason. The method of killing, able to overcome the traditional resistance mechanism and being able to target specific cells. Neurotoxicity is a serious side effect of CAR T cell therapy in lymphoma, leukemia, and same in myeloma. Neurotoxicity basically means that there is some disturbance of neurological function connected with the CAR T infusion. We are not going to discuss what causes that. There are multiple reasons, could be T cells themselves, could be immune reasons, could be inflammatory changes, could be cytokines. However, it is graded in a very defined way. It is graded by what is called ICE score, or it is graded by algorithm where grade 1 is where patient has some depression of consciousness, but patient can be awakened spontaneously. There are no other immunological effect. Grade 2 is when patient is level of consciousness is low, but he can be only awakened by the voice. Grade 3 is when patient requires a tactile stimulation for awakening and may or may not have other clinical seizure, which are focal or rapid resolving generalized seizure, etc., with EEG changes, but no other weakness or neurological deficit. And grade 4 is when we cannot wake up the patient and or are more serious seizures and others. And the management is reasonably straightforward. Grade 1 and 2 neurological toxicity is typically managed by supportive care, doing the diagnostic workup, giving medicines to prevent seizure, and also to have some way rule out cerebral edema. Grade 3 and sometimes even grade 2 neurotoxicity will then need to be treated more aggressively. Patients, besides getting the supportive care, would need to get dexamethasone, usually 10 to 20 milligram dose given IVs every 6 hours or something similar dosages. Definitely control for seizure using benzodiazepine or similar other anti-seizure medication, and in some cases even using higher dose steroid. Tocilizumab use is always considered as part of the treatment for it, although it is mainly reserved for treatment of traditionally CRS. And grade 4 toxicity requires all of this above with some other supportive care, which may require hyperventilation, hyperosmolar therapy to decrease cerebral edema, mannitol, etc., and also consultation with neuro-ICU colleagues to have more active measures. But very active, quick treatment of neurotoxicity, especially grade 3 or higher, is required. Now, in KarMMa study of 128 patients, the neurotoxicity observed was around 17.3%. However, grade 3 neurotoxicity was very small. Very few patients had grade 3 neurotoxicity. In the other studies, the EVOL studies, it was 13.3%. In CARTitude, it was 10.3%. So CARTitude had smaller number of patients enrolled. EVOL also had a smaller number of patients enrolled, 62 and 29, or 29 and 62. So basically, between 10 to 17% is the range. I wouldn't call one having a higher neurotoxicity or other one having a lower neurotoxicity. I think the neurotoxicity ranges from 10 to 20% in this patient population. In almost all of this study, it has been predominantly grade 1 and 2 neurotoxicity. So grade 3 is quite infrequent. So in general, I would feel that in myeloma compared to other malignancies, the neurotoxicity frequency is smaller, meaning less frequent, and also is of lesser intensity. In KarMMa study, for example, grade 3 was 3%. So I don't think neurotoxicity is a major concern in BCMA-directed CAR T cell therapy. So that's a very important question. The dose of CAR T cells and response, and dose of CAR T cells and toxicity. So in the KarMMa study, there was clear dose-response relationship identified. Patients getting 150 million cells, 300 million cells, and 450 million cells, 450 being our target dose, there was a clear increase in people having overall response and the complete response. So I think maintaining a higher dose is important. But similarly, there is also some relationship with dose and the CRS. So 150 million, the CRS was 50%, 300 million, it was 76%, 450 million cell, it was 96%. But importantly, the CRS in all of this dose range was of the lower intensity. So CRS and dose is not a major concern. 450 million dose, which is the higher dose, is not a dose with significantly high-grade CRS. So I think maintaining the higher dose, 450 in KarMMa study, is important because the responses are higher, and very clearly, both pre-FS duration of response is also significantly higher. If you look at the patients having 450 million cells, the PFS was 12 months, and I think that's a very important number to keep in mind. So I think maintaining the higher dosage is important. For neurotoxicity, no clear dose-response relationship was observed. So higher dose doesn't mean higher neurotoxicity. And same way, cytopenia is not connected. So I think currently we need to use the higher dose where we get better efficacy and also higher frequency of CRS, but not the higher grade of CRS. And so I think currently the plan would be to go for the higher dosage, and there is less requirement to individualize the dose. Now, when other products will become available from other companies and other investigators, then we will have to study if there is any need for personalized dose where we can give the CAR T cell based on the body weight or blood volume or some such measures. But currently, a fixed dose in KarMMa was good enough to give both high response rate and manageable CRS. That is also a very important question, and we and others are really studying what is the reason for relapse after CAR T cells. From the current smaller studies done all over, including the KarMMa study and the other study, it looks like loss of BCMA is not the primary reason. There have been few cases where that has been observed, but that's not the primary reason, only a small number of cases. So one of the important point would be that lack of persistence, that CAR-T don't survive very long, and that may be one of the reasons for relapse. Number two, the change in the immune microenvironment could be a major issue. Number three that we still need to study is that some of the sites, extramedullary sites, where tumor may be able to have a shelter and be protected from CAR T cell. And that could be in some of the cases uh, part of the reason. And also the immune and non-immune microenvironment in the bone marrow as well as in the body can be playing some role. So I think the relapses after CAR T cells are probably connected with multiple different mechanisms, loss of BCMA being a minor, real but minor reason in this case. And so once we study about what drives this, we'll be able to tell us how to overcome it. And the more important point right now is that the CAR T cells are given as one infusion, no maintenance. And in myeloma, no treatment is like that. For even after transplant, we have a long Revlimid maintenance. So I think to prevent relapse, we'll have to come up with strategies that will maintain the very good and deep responses we get with CAR T cell therapy. I think that's very, very important and a very good question. Your observation is very true. 88% patient in the KarMMa study required bridging therapy. That tells you that patients have very aggressive myeloma and that we cannot even hold it without treatment for 4 to 5 weeks. But it's a good initial result that establishes the proof of principle that CAR T cells work very well, very deeply, and can provide reasonably long-term remission. Now the task is what you're asking. Can now we be doing it sooner? And the answer is absolutely true for multiple reasons. It would be good to use CAR T now in second line and maybe even newly diagnosed cases, because that's where the cells are very sensitive. They are still not extramedullary, so they may not have sanctuary sites and can be very effectively killed. So that's one very good reason. Number two is what you said. The tumor burden does affect the CRS. High tumor burden, more CRS, more toxicity. So we may now need to learn to first bring down the tumor burden and then do CAR T so it could be more effective. So there are a number of studies ongoing currently at an earlier stage of the disease. In second line treatment, there are CAR T cell studies ongoing in newly diagnosed patients with high risk myeloma so that they can be treated. Also in patients who are coming out of transplant with residual disease or relapsing quickly after transplant is another setting where we are studying CAR T cells. So I think in very near future, you will see a number of studies where CAR T cells are being utilized at an earlier stage of the disease. And this is where its main action and main utilization will happen in future so that we might be able to even cure this disease very soon.